Greetings. In this video, we describe the first report of meniscotibial ligament avulsion repair with arthroscopic suture anchor fixation. Similar to a ramp lesion, MRI sagittal views are the best for anticipation. Bone bruising at the posteromedial tibial plateau is suggestive, and often we can see disruption in the meniscotibial ligament itself or its avulsion from the tibia. By definition, ramp injury is a meniscocapsular separation, including a meniscotibial ligament tear. However, in the reverse ramp, the injury is closer to the tibial attachment rather than the posterior horn itself. We have only seen a reverse ramp injury in the context of a combined ACL and PLC injury, and we do hypothesize an excessive AMRI pattern as a cause of this injury. These stressed views here highlight the failed lateral complex associated with a positive Ligament. Therefore, with a high index of suspicion, we should look out for anteromedial rotational laxity during our diagnostic scope. We can see here the significant forward translation of the medial tibial plateau with external rotation of the tibia suggestive of the AMRI pattern. In addition, anterior probing of the medial meniscus will not reveal any hypermobility, which is the opposite case with a standard ramp lesion. The skin landmarks are critical for the first posteromedial portal, so with the knee placed in 90-degree flexion, two horizontal lines are made. The first is drawn at 3-finger breadth from the superior patellar pole. The second is tangent to the tip of the inferior patellar border. The landmark for needle insertion is just posterior to the intersection of these two lines. At this point, with the transnod view established, a needle through the posteromedial portal is used to examine the superficial meniscocapsular junction, which typically does not reveal any injury. For easier suture manipulation and anchor fixation, we advise the use of a transseptal approach for viewing. The first step is to bluntly dissect the meniscocapsular junction inferior to the joint line to create a small working window until the posterior tibial cortex is palpated. An anchor is then inserted distal to the tibial margin, keeping in head that the meniscotibial ligament insertion is 6 mm below the joint line. A switching stick or probe can help with tissue handling by applying some counter tension at this point. Once the anchor is deployed, the sutures are shuttled through the anterolateral portal. The use of one double-loaded anchor is often sufficient for fixation. A suture hook repair is typically used in these cases. The curved spectrum is used to pass through both the meniscocapsular junction and the meniscotibial ligament, which often gives a different biofeedback. Simple or mattress repair can then be done with a sliding SMC knot. Suture manipulation through the notch is easier with knee and slight extension rather than 90-degree of flexion. Finally, external rotational laxity of the tibia should be reduced with repeat arthroscopic examination. Thank you.